the ICU. So how do we defer these patients? Okay, starting with diabetic ketoacidosis, it's a triad of hyperglycemia. Next. It's a triad of hyperglycemia, which the sugar levels are above 11. That is the guideline, what it says, with high anion gap metabolic acidosis and ketosis, which a bit differs to HHS, previously was called hyposmolar non-ketotic state. So that is defined as with hyperglycemia and hyperosmolarity. Now, hyperosmolarity, if we talk about that, they are the three key players. This is glucose, sodium, and urea. If you just have sodium and glucose, you'll definitely get the number of hyperosmolar. So if we have to talk about these are the complications which patients do present. A is more specific for type 1, but type 2 can get it. HHS is for type 2 diabetes patients, but even type 1 do get. And 1/3 of the population, they have overlap of both DKA and HHS, about 1/3. So let's dive in back in history. Okay, I like history just to know about DKA was really talked about and being diagnosed. So I think everyone knows a famous name, Kussmaul breathing, deep, shallow, fast breathing. Okay, deep, shallow, fast. That was named after Adolf Kussmaul breathing. But apparently he did not write a paper describing DKA. His colleague did in somewhere 1880s. When that breathing was described, was pointed out to a patient, that was almost a death sentence, or maybe because at that time insulin was not yet discovered. So till 1920, automatically the mortality was almost 90 to 100%. It was, as I mentioned, it was a death sentence. But after the discovery of insulin from porcine and bovine, so the mortality in 1930s, it dropped down till 29%. However, yet doctors did not know what is the accurate doses of insulin that we have to give. Should we give low dose insulin or high dose insulin? So the aim was at that time was to target sugar levels in DKA and HHS. They were not targeting the acidotic component or hyperosmolarity component, which we'll talk about in the coming slides. So many of these patients used to get high doses to the point that they end up discovering that, especially pediatric age group, got cerebral edema by shifting high amount of glucose intracellularly. Cells end up swelling because pushing water into the cell. So by 1970s, everyone started learning from their mistakes in the past. So the mortality dropped down till 10%. On the other hand, if we're talking about this part of the world, Tanzania, a paper was published in Bugando, Mwanza, 2017. Mortality rate of DKA in Tanzania is about 24%. We still need some work to be done. So talking about DKA, so it's one of the life-threatening condition, in mostly commonly in type 1, but yes, type 2 can happen. Okay, and if it happens or it evolves very fast within 24 hours, and they end up having a distinct feature of fast breathing, which is known as Kussmaul breathing. So not all diabetic patients, I know many diabetics around at our place, in our clinics, not everyone gets DKA or HHS. There has to be a trigger, okay? So these are the reported triggers. It has been found that the patient end up getting into DKA or HHS, whether it's type 1 or type 2. So they'll end up getting this kind of complication. So most top 2 has been noticed if the patient is poor adherent to their medications, whether insulin or oral medications, and also infection. Even in the Mwanza study, they found about 52% of the patients, the trigger was an infection. But all in all, with the infection in the western part of the world, they found pneumonia and urine infection was the key trigger patient going into DKA and HHS. Next. So, how the pathophysiology works about. So, in the presence of the trigger, okay. So, insulin is the only hormone which lowers down the sugar. On the other hand, there are other hormones which are called counter-regulatory hormones. What did that do? They rise up the sugar. One against many. So due to that component, which we call stress hormones, the insulin gives up the war. And because of the whole hormonal imbalance, I think I'll just take you back into biochemistry, gluconeogenesis, glycogenolysis, and importantly, because of insulin deficiency, lipolysis do happen. So this is a very big thing. I'm not going to talk about each and every part. So here, what thing happens in the absence of insulin, especially absolute absent? So there is a lipolysis on your left side. If a lipolysis do happen, there's a breakdown of free fatty acid, which leads to the production of ketoacid, which leads to acidosis. And all in all, it causes hyperglycemia. And at the end, because of the osmotic diuresis or fusion, they end up getting lactic acidosis. So the key thing here is when the patient comes in here, it's not the hyperglycemia is life-threatening, is the metabolic acidosis is life-threatening. So our key aim during the treatment of DKA and HHS is not targeting to lower the sugars from 30 to 8 in 3 hours' time. That's really bad, which moves the fluid intracellularly. They end up getting cerebral edema. So by saying that, our key aim is to break the chain. Giving insulin is not targeting the sugar, but to inhibit ketoacidosis not to keep on happening. So what kills the patient? Is it the hyperglycemia or the acidosis? Obviously, acidosis. If you are aware of the 5H and 5Ts of the cardiac arrest, there is nowhere hyperglycemia is the immediate cause of death, but metabolic acidosis is. So our key aim in this situation, we have to focus on lowering down the metabolic acidosis to neutral. So DKA has been classified into mild, moderate, and severe based on pH and bicarb levels. And they are classified based on their altered level of consciousness. So mild is level somewhere 7.25 to 7.3. Anything level 7.3, that's really acidosis. I think just to go back, what's the normal pH of a human body is 7.35 to 7.45. So anything less than 7.30 definitely is a DKA. So where the patient falls in, mild, moderate, or severe. So coming to HHS, unlike DKA, they develop the whole symptoms, hyposmolarity, and they are more sicker compared to DKA. They have altered level mental of status because of the sodium levels and even the glucose. So these are the two key players which I'm mentioning. So the sodium levels, I think everyone knows, is 135 to 145. Their levels will be like 160, even I've seen 190. So leading to profound dehydration, pulling out all intracellular fluid extracellularly, the whole cell shrinks. Apparently, they lack ketoacidosis. We'll talk about that. And their sugar levels, as per the guidelines, are more than 13 compared to DKA. So the actual pathophysiology of HHS is really not known. Why it does not cause ketoacidosis? Because any type of other acidosis, they do have some form of ketoacid production. But in HHS, why they don't have, there is three theories behind. One of the theory behind is because probably it's a patients in type 2 diabetes, they have enough insulin. They lack lipolysis. And if they lack lipolysis, they also have a less stress hormones compared to type 1 diabetes. And also, finally, that's the third theory, being a hyperosmolar state also contributes them not to inhibit lipolysis. So this is just to show you how things are. They do not have lipolysis because they have abundance of insulin. Okay. And being hypoglycemic, definitely they will have osmotic diuresis. What the kidneys will do, will try reabsorbing enough sodium and chloride, and the sodium and chloride keeps on rising. So how we defined HHS in comparison to DKA based on the blood gas and electrolytes. Okay. So this is a bit different. It's opposite of what we saw in the previous slide. Anything pH less than 7.3, that's an acidosis. But here, everything is up, 7.3 above. Bicarb levels are above. In comparison to in DKA, the bicarb was on the lower side. Just for everyone's information, bicarb normals is 22 to 26. And important part here in HHS, because we are talking about hyperosmolarity due to what? Hyperglycemia. It's calculated, osmolarity 320. How do you calculate it? 2 times sodium plus glucose, BUN. Like if you don't have glucose on BUN and if the patient presents with sodium on 160, multiply 160 by 2, 320, you are done. And if you add up like the glucose of 30, comes 350. So that's hyperosmolar already. How these patients do present? So there are specific signs that you'll see in patients of DKA, a distinct Kussmaul breathing. I know it doesn't happen to every DKA patients, especially if their pH are like above 7.2. And the essence of having Kussmaul breathing or deep fast breathing is to push out carbon dioxide. Why to push out carbon dioxide? Why? Is to try to buffer up the primary metabolic acidosis. As you can see the equation, and going back to school, hydrogen ion, bicarb, carbonic acid, and you end up getting water and carbon dioxide. So the bicarb for the kidneys, carbon dioxide for the lungs. So primarily you are acidotic. CO2, if you keep on blowing out, you try to buffer up to maintain your pH. Apart from the Kussmaul breathing, some of the patients of DKA, they have general abdominal pain. That's also a distinct feature of a DKA. I know it's not like all the patients will have an abdominal pain, but at least those patients with the pH above 7.15 or above, they will have generalized. That could be anything underlying intra-abdominally, pancreatitis, SBP, spontaneous bacterial peritonitis. The key thing here, what happens because of the acidosis, they end up getting ileus and gastric emptying gets inhibited. What about specific signs to HHS? HHS, since it's more of an insidious process, till a patient or till the relatives try to notice, it takes like about even 3 to 4 days unlike in DKA. DKA evolves faster, can start having Kussmaul breathing within 24 hours. But HHS, it takes like even a week, then going into stuporous to coma. And they may present into stroke-like symptoms. They might get hemiparesis to the point that they even present with seizures. You can get confused. Patient, we're dealing with a stroke, intracranial hemorrhage. So CT scan is really important to know what you are dealing with. And their level of consciousness are so low to the point that they may require to be intubated. So what are the key investigations are done? So we need to know first the cause and what are the complications. So the causes, of course, you'll just come to know from basically 3 or 4 tests. Number 1, your blood gas. Number 2, RBG, any sugar levels, at least you get an idea. The blood gas, what should we be done? Arterial blood gas or venous blood gas? Preferably arterial, but a study were done, there is no big difference, just a difference is of 0.03. So venous is fine because we are not really paying attention to the PO2, partial pressure of oxygen. We are more focusing on pH, CO2, and bicarb. That's all. And and you need some electrolytes that you can do a calculation to measure osmolality. And rest of the test can be done just to find out what is the real cause of this DKA and HHS. So just to summarize, I know it's like a very crowded table, mild, moderate, severe, based on in relation to their mental status. Mild are with pH less than 7.3, moderate somewhere less than 7.2, severe less than 7.0. In comparison to the HHS is more than 7.3. And even if you see the bicarb, anything the number less than 18, and compare to the HHS, the numbers. So HHS is more alkalotic rather than DKA. DKA is more acidic. But what really differs is the osmolarity if you look at down. DKA can have hyposmolarity, but HHS, they do have a profound osmolarity, even to 400 or 450 milliosmoles, in comparison to DKA. DKA can range to about 290 to even 330. As I said, they can have an overlap of DKA and HHS in a patient. So just to understand about what is an ion gap, okay? An ion gap is a measure that to see the balance in the extracellular space, which is calculated, balance of cation and anion. And this is very important to look into patients with metabolic acidosis. So we can differentiate whether it's a high anion gap or non-anion gap. The key players are the chloride and the bicarb. The chloride representing the acidic anion, bicarb representing the basic anion. So any number, especially if the chloride goes high, it tries to dilute the bicarb, you end up getting non-anion gap metabolic acidosis. We'll talk about that in the coming slide, but at least this is the thing that at least I want to let you know what is a normal anion gap. So normal anion gap is anything the number between, depending on which references you are using, 9 to 15, okay? Above 15 is considered high anion gap metabolic acidosis, acronym or abbreviated HAGMA, normal anion, AGMA. So interesting part, everyone would like to learn how do we manage this. We learned about the whole pathophysiology, we know about DKA, we know about HHS, we know patient breathing fast, deep, shallow breath. So how we manage? So goals of acutely managing this life-threatening condition of diabetes, whether it's DKA, whether it's just 4 things. Correction of hypovolemia, and that is done by fluid. Of course, not letting the patient drink water. They will be not able to drink lots of water. And these patients are really, really dehydrated, really dehydrated. So choice of, that will be IV, intravenous fluid. Number 2, gradual correction of ketoacidosis and hyperosmolarity. With what? Insulin. And not correction of glucose. We want to take them out from the danger of ketoacidosis, which is a life-threatening situation, and hyperosmolarity. Because if they are normalized from the ketoacidosis, they will eventually still be diabetic. It's not like you're going to cure the diabetes. You are curing the ketoacidosis and hyperosmolarity. And the doses are not high doses, low doses. If you give high doses, what will happen? It will push the glucose intracellularly, which creates intracellular hyperosmolarity. Pushing water intracellular rapidly, the cell swells. So that's a lethal part that we have to be careful. That we learned in the past in 1930s. We should not repeat those mistakes at this era. And correcting electrolyte abnormality. It's only one major electrolyte that we need to focus on, is potassium. I know there are other electrolytes, but they've been studied upon, but at this time, it's only potassium. Because during the treatment, giving insulin, it lowers down the potassium. Why it lowers down the potassium? It pushes the potassium intracellularly, and apart from the osmotic diuresis happening, there is a lowering of potassium. Plus or minus magnesium supplements can be given. Okay. And the final point is to identify the trigger and treat simultaneously. If you do not, the DKA or HHS will never resolve. And finally, of course, during this point of time, the patients are very critical. They need to be monitored in either ICU or HDU setup. They need close monitoring, vitals, sugar every hour or 2 hourly, blood gas every 3 to 6 hourly, depending on the resources you have, electrolytes, same 3 to 4 hourly, and importantly, catheterizing the patient and knowing the input and how much the output comes out. So going each step, correction of hypovolemia. So it's obviously giving fluids. Now, what type of fluids? What type of fluids? I know everyone would say, give normal saline that had been given for past a century. An average fluid deficit in DKA is about 100 mils per kilo. That's in a 80 kilo, they have a deficit approximately 8 liters. But HHS has about times 200 mils per kilo. That's about 16,000. And type of fluid, of course, not normal saline. Why not normal saline? Back in the days, we were told that normal saline is an isotonic solution. Well, it's not. If you happen to remember or seeing the ingredients of a bottle of normal saline, sodium has 154 millimole per liter. Same, the chloride has 154. So why it's a big deal? Because the serum chloride, if you measure from a lab, it's approximately 98 to 100, let's say about 100 millimole, which it's more hypochloremic. And what is the clinical significance? It has been found on many observational studies. It causes hyperchloremic acidosis, and later on, it causes a patient going into AKI. How it does that? It vasoconstricts at the afferent arterioles, reducing the GFR. The bicarb reabsorption at the proximal tubule reduces, and eventually no urine output. And that had been also observed in a big study done in 2018, which was published for patients comparing not DKA, different type of patients. They compared a balanced electrolyte solution, preferably whether plasmolite or ringalactate versus normal saline. So what's plasmolite? I know in Tanzania, we don't yet have a plasmolite. We have ringalactate. What's the difference based on the ingredient? Ringalactate, apart from the sodium and chloride, the numbers are lower. It has but it has acetate and gluconate. So they did a study. They found that if you see on my right side, the chart saying that as that received normal saline, their chloride content were more higher and the bicarb level low. And there was statistically significance saying that saline caused AKI in patients with critically ICU patients. Parallelly, they did a study similar for patients who were non-ICU patients, and similarly, they found out AKI was caused by NS more compared to patients received balanced electrolyte solution, whether RL or plasmolite. Coming to DKA, what type of fluid is more preferred? A meta-analysis was done and was published somewhere this year, and they collected about 7 randomized controlled trials and observational studies, which gathered about 1,000 patients. What the authors found out that balanced electrolyte solution resolves DKA faster compared to the saline. And obviously, the chloride was lower and with elevated bicarb in balanced solution. So they proposed, if we happen to make a guidelines, try to consider balanced electrolyte solution in Tanzania, consider ringalactate instead of NS as a first choice during fluid resuscitation in patients in DKA. So having said that, not normal saline, for us should be ringer lactate. So that should be your first choice of fluid. How much to be given? I know different institute, different guidelines, okay, based on the resources. So these are the recommendation had been said that to begin with, we can give 20 mils per kilo as a boluses, can be 20 mils per kilo per hour, for 2 hours, for 3 hours, depending on the hydration status, and maintain with 5 to 14 mils per kilo per hour. So just to summarize up, either 1 to 2 liters per hour for an hour or for 2, and then maintain with 125 or 100 to 250 mils per hour based on the hydration status. That should be ringer lactate. In case the sugar drops, the glucose drops to less than 14, our aim is not to lower the sugar very fast, because the thing, if we start lowering the sugar, what will happen? There will be a transcellular shift from the extracellular intracellularly, the cell end up swelling. So if the sugar drops, we have to maintain the hyperglycemic state, not completely euglycemic immediately. Of course, we are aiming also to euglycemia, but not in 3 or 4 hours. Okay? Gradually, the fluid from ringer lactate can be switched to not DNS. The recommended is dextrose 5% with 0.45%. In my practice, I haven't seen that, nor any suppliers have supplied any hospitals, even including mine. So what practice I do, I use D5 water. That's fine. That's fine. It's just you are missing 0.45%. That's fine. You can use D5. And that's the maintenance. You can continue with 125 to 250 mils per hour. And also try to be considerate for patients with heart failure and renal failure patient. So there is no concrete guidelines, but the recommendation based on the expert opinion, try to just give aliquots of boluses and maintain with insulins rather than going with a high amount of fluids to avoid fluid overload. Talking about insulin, insulin again is not to reduce the sugar while treating DKA or HHS. Aim is to lower down or gradually lowering down the ketoacidosis and hyperosmolarity. And it's recommended to be given at least after 1 hour of giving enough fluid. It helps to the perfusion, and what it helps is just to cut down the chain. If you cut down the chain, no lipolysis. Lipolysis, no ketone, no acidosis. So that should be done gradually rather than very rapidly. Okay, next. The recommended dose is low dose insulin, 0.1 units per kilo per hour. Considering I have an 80, how much insulin I'll be giving? That's like 8 units per hour. If you have a luxury of an infusion pump, fair and well, you can do the whole math and giving the patient 8 units per hour. So just in that, you know, the insulin syringe, it has 4 bars with even numbers, 2, 4, 6, 8, giving a patient per hour. It's not really practical in an IV setup. You need to make a concentration and give it over an hour continuously. There had been a study, if you do not have IV infusion sets, syringe pump or infusion pumps, you can opt to give either IM or sub-Q every hourly, every 2 hourly, or 3 hourly, depending on what studies you are following up. But more recommended is either 1 hourly or 2 hourly. So the key aim is to not lower the sugar, but maintain or reduce the ketoacidosis. And if the sugar levels tries to drop to 14, the insulin gets halved from 0.1 to 0.05. If the 80 kilo patient was getting 8 units per hour, ends up getting 4 units per hour. The important part is potassium. Because the patient is having diuresis, they lose up so much of potassium. I know the first reading, when you end up getting your electrolytes, you will end up getting potassium maybe 7, 6. That's ideally more of pseudo hyperkalemia. Don't jump to hyperkalemia protocol. The point here is that's a false reading. Unless otherwise the patient always correlate with the ECGs. If they have peak T waves, prolonged QT intervals, or any sine waves, then consider giving hyperkalemic protocol. And this is our more common in patients with CKD. Having said that, these are the things that you can give based on your potassium levels. If potassium levels are more than 5, you can delay. No problem. You can delay. But make sure you do your electrolytes at least 3 hourly, that you can focus on your potassium levels and maintain or target your potassium levels between 4 to 5 during whole treatment of DKA. So potassium chloride should be given at least 2.5 to 20 millimole per hour. In case some patients, they have a refractory hypokalemia, how much you are about to finish the pharmacy with all your potassium chlorides, the potassium do not climb up, do not climb up. It's really wise enough to give magnesium sulfate, just a shot, which can run over the period of 30 minutes or even 2 hours. Then you'll start seeing the potassium normalizing. So being considered. And lastly, treating the underlying triggers. If you treat the triggers, DKA resolves, HHS resolves. Talking about bicarbonate, it's a very controversial point. Controversial topic. I know you'll be having the bicarbs are low. Why can't we give bicarbonate? Back in the days, bicarbonate were being given in somewhere 1980s, 1990s. What they found out, it not only causes hypokalemia because creating extracellular alkaline situation and pushing potassium intracellularly, but also it ended up causing cerebral edema. How? Pushing hydrogen ion intracellularly, CO2 climbs up, causing cerebral edema by building up CO2 and vasodilatation. And then they end up getting tissue hypoxia. Only one recommended situation if it happens in your treatment of DKA. If pH, and this is on expert opinion, not as per the study, if pH is less than 7 and with the bicarb levels are less than 5, consider give sodium bicarb. About 100 millimole, or what if you are using equivalent, that's almost the same number, 100 milliequivalent, add up in a 400 mils, either dextrose or water if it's available, run it over the period of 2 hours, that's 250 mils per hour. And not to forget to add KCl, because not only insulin drops the potassium, even sodium bicarbonate drops the potassium. And just to KCl not to be given for patients if you are thinking patient having CKD. So when to stop DKA treatment or HHS treatment? There has to be an end. So what's the resolution criteria? For DKA, the anion gap has to narrow down. It has to normalize. So what are the numbers? Less than 12, pH coming to normal, more than 7.3, bicarb more than 18, and patient who has totally stuporous on coma is able to eat and maintain it well. In comparison to HHS, is target, it's not yet still glucose, but osmolarity. If the osmolarity is gradually dropping 320. So what are the time period of the resolution? DKA resolves faster in comparison to HHS. Resolution of DKA happens over the period of 12 hours, whereas HHS, you have to be really patient. Resolution happens after 48 hours. So HHS, you have to be really patient as they develop gradually and they resolve gradually. So when to stop insulin infusion, if you're using infusion or the sub-Q short-acting insulins, and go back to the insulin regime. As for the expert opinion, they said, even my practice, I give insulin, either intermediate acting or long acting glargine, at least 2 to 4 hours prior stopping the insulin infusion. But a study was done this year in somewhere in January. They introduced insulin, that's glargine, when a patient is diagnosed with DKA from time 0. They get their shot versus those patients did not get the shot. What they found out, the DKA resolution was faster in comparison to those patients who did not get the basal shot. And also the ICU stay for patients who got basal insulin was at least a day in comparison to those patients who did not receive basal insulin, which was about 4 days. This is a bonus info. Why I would like to talk about iatrogenic hyperchloremic acidosis. It's a point that we usually iatrogenically cause or induce to patients when we're treating DKA. What we end up giving, not only normal saline, even ringer lactate. What it had been noted that it ends up causing hyperchloremic acidosis. What's that? Increase of plasma chloride, which is a acidic anion, reducing down the basic anion, which is bicarb. In other terms, it's a dilutional acidosis. So far, it has been documented or found in 3 situations. The first situation is somewhere 1980s during cholera time, after losing out so much of bicarb in the GI, and the kidney tried to reabsorb sodium in chloride. They observed much of bicarbonate loss with subsequent chloride retention. And number 2 is defective tubules. These are commonly known renal tubular acidosis. What of interest is, right, with us causing iatrogenically by giving normal saline. What are these? It's by saline. Okay, next. We correct hyperchloremic acidosis. Basically, what is it? It's bicarbonate deficiency. I know I mentioned that there is a controversy giving bicarb in DKA. Yeah, that is sure. Giving bicarb in DKA, it's a really controversy. Giving it is causing more harm than benefit. But in hypochloremic acidosis, bicarb therapy, since it's a bicarbonate deficiency, there's no controversy as yet. You'll have some patients with DKA, whether given RL or NS. If you end up seeing the pH is not normalizing, but anion gap is normalized, the bicarb are still on the lower, but the chloride is climbing up. Try thinking that it's a doctor's mistake or nurse's mistake, that we ended up causing extra part of acidosis, forgetting about ketoacidosis. So what are the doses which have been recommended? It's about 2 to 5 millimole per kilo per day. That's approximately the small vials you can end up giving for an 80 kilo adults, about 20 to 40 per day. And keeps on continuing. So with that, I would like to thank you.